One thing I think that we don't talk about a lot with gemdosi is that it's very burdensome in your clinic, right? So even if you're using the shorter installation, so the original study was 60 and 90 minutes, right? So those patients are there for a long time. And we've gone down to doing 60 and 60. Those patients are still there a long time. It requires a lot of staffing from our clinic nurses. They spend time in the room. Plus then, you have various regulations about how you clean up after you've been giving chemo. And so from our standpoint, that's actually an extremely burdensome patient versus a 1 hour Adstiladrin, that they come once every 3 months for. So it's sort of interesting how these things play out versus in the community, they can't give gemdosi at all in a community urology office because they're not equipped to give chemotherapy, right? Because they don't have that level of, they're in an office building or right, something like that. They're not attached to a hospital the way that we are. So I think some of these things play out not necessarily because of efficacy or in an evidence-driven way, but based on the resources that you have available to you and what you can give.
So coming back to the BCG naive setting, in which patients would you offer the Potomac or CREST data to offer patients like giving a durvalumab or a saselimab?
Yeah, I thought that data was very interesting in that it would have been really nice if you could show them that they didn't need the BCG maintenance. If they got the systemic IO, it would have felt like a better trade-off. But instead, there just seems like a significant escalation, both in terms of burden on the patient and also potential side effects. So I think I would think of that for somebody who I would never have my bladder out. Just give me the very, very best chance that you can, and then I would probably try that for them. But a lot of patients really don't want the systemic side effects.